Good morning, everyone. On behalf of Boston Children's Hospital and the Fetal Care and Surgery Center, thank you all for joining today's webinar on fetal anemia. My name is Cassandra Duffy. I'm a maternal fetal medicine specialist at Beth Israel Deaconess Medical Center and also at Boston Children's Hospital. And I'll be starting off the webinar for us today. I have no disclosures to report. Sorry. So I'm going to start off with a little bit of background about fetal anemia. I'll mostly discuss alloimmunization and prevention strategies. And then I'm going to hand it over to my colleagues who will discuss screening and treatment of fetal anemia, the important topic of neonatal care and management, and then we'll end with some exciting updates and innovations in research. So as we all know, there are many different causes of fetal anemia, encompassing immune, infectious, inherited or genetic, and other etiologies. And fetal anemia may be picked up through screening, which we'll talk about in the next section of today's webinar, and also through ultrasound findings concerning for fetal anemia. And depending on the underlying etiology, the severity, and the chronicity, these presentations may vary. The most common causes of fetal anemia in the United States are maternal alloimmunization and parvovirus. But for the purposes of today's webinar, we'll mostly be focusing on alloimmunization and hemolytic disease of the fetus and newborn. So the two main causes, as we all know, of maternal alloimmunization are sensitization through exposure to fetal antigens during pregnancy, which can happen at multiple time points, or through exposure to foreign antigens at the time of blood transfusion. And rates of Rh alloimmunization have fallen dramatically since the advent and introduction of Rh immune globulin prophylaxis, which was introduced in the 1970s. Prior to this point, it was estimated that up to 16% of at-risk pregnancies had Rh alloimmunization. Following the introduction of postpartum use of RHIG, these rates fell to less than 2%. And then after the addition of routine antepartum use of RHIG, these rates fell below 0.2%. So this is kind of a true success story in terms of the primary prevention of Rh disease. In addition to routine use at 28 weeks and after delivery, or within 72 hours after delivery if the newborn is positive, ACOG also recommends prophylaxis for a variety of other indications during pregnancy, which are summarized here. However, it's important to note that there's much more limited evidence for these other indications. And there is really no high-quality evidence or randomized controlled trials showing benefit of prophylaxis in the reduction of alloimmunization when given in the first trimester. Nevertheless, ACOG does recommend the use of RHIG for all terminations of pregnancy, and given the high stakes of Rh disease, also endorses considering its use for first trimester miscarriage. In their practice bulletin, they don't really comment on indications in the setting of threatened abortions or bleeding in the first trimester, though we all know it's commonly used for these indications. So I'm going to transition here to some postnatal data just to illustrate the prevalence of Rh disease. This is a retrospective observational cohort using data from the National Hospital Discharge Survey that looked at live births from 1996 to 2010. And the authors separated hemolytic disease by type, including Rh disease shown in the top in dark blue, ABO alloimmunization, which, though much more common, we know is much more mild and less clinically significant during pregnancy, and then other antigens. So even though RHIG was introduced, decades before this study started, the authors speculated that they saw a continued decline in Rh disease in live births over their study period due to other policy and practice changes that were happening in the 80s and 90s, including indications for prophylaxis other than just delivery antenatally, and then also screening for fetal maternal hemorrhage. And worth noting that the numbers for Rh disease reported here in a US cohort are comparable to limited data from other countries as well. So despite successes in Rh alloimmunization, anti-D does remain one of the most common antibodies detected in maternal samples. This was a recent nationwide study that looked at nearly 10 million maternal samples that went through a large commercial laboratory. And they found that in this maternal cohort, 1.5% had a positive antibody screen, 0.9% had a clinically significant specific antibody reported, and of these, anti-D was the most common. This study did include potential anti-D that was due to passive immunization from RHIG as well. But only a small fraction of these anti-D samples had a critical titer, which they also looked at in this study. And you can see the other sort of antigens assessed by risk status as well. Anti-Kel, for example, had the majority of cases actually had a critical titer. These graphs actually come from the same study, which are looking at the prevalence of the 3 highest risk maternal antibodies over the study time period. And they show that the presence of all 3 increased significantly during this time. So anti-D is shown in the blue here, anti-Kel in red, and then anti-C in green. However, the frequency of critical titers for anti-D fell during the study period. So that's shown again in the blue on the right graph. While meanwhile, the presence of anti-Kel antibodies increased significantly, about 25%. So the decrease in the anti-D critical titers sort of fits with the story from the postnatal or neonatal data as well. So despite evidence of decreasing critical Rh disease, we know that anti-D is a large contributor to fetal anemia and the need for treatment during pregnancy. This data is from a nationwide Finnish study of all intrauterine transfusions that were performed there over a period of 10 years. And the majority of these, as you can see, were due to Rh disease. And it's worth noting, clearly this is not a US population, but Finland does use similar prevention and screening practices for Rh disease. And these findings are also similar to smaller single center studies of IUT indication from US institutions. So I'm going to switch gears a little bit here to begin the discussion of the management of maternal alloimmunization during pregnancy and assessing those pregnancies that are at risk and need further screening. So this process is twofold. It involves both the assessment of maternal antibody titers as well as fetal antigen status. And these processes can happen concurrently. Historically, the process for the latter has involved assessing paternal antigen status and zygosity. And if the paternal antigen is positive and heterozygous, or if it's not known, then the next step involves assessing fetal antigen status through diagnostic testing. However, this classic paradigm is sort of fraught with challenges, including the need for serial maternal blood work and resources for the blood bank and transfusion medicine in terms of assessing titers. Paternal antigen testing is very fraught due to uncertain or potential unknown paternity, as well as partners simply not being available or having barriers due to insurance issues. And then amniocentesis for fetal antigen testing, of course, is an invasive procedure that patients may be hesitant to undergo. It cannot be performed until after 15 to 16 weeks, and it has the potential to increase sensitization as well. So wouldn't it be wonderful if we could circumvent many of these challenges and proceed directly to an option for non-invasive fetal testing when we have maternal alloimmunization in pregnancy? And indeed, this was first reported in 1993. So Lowe and colleagues reported on non-invasive fetal antigen determination by maternal blood in a letter to the editor in The Lancet. And they found that in all of their cases of Rh sensitized maternal samples, 100% concordance in the detection of Rh antigen in comparison to fetal blood sampling during those pregnancies. And this report was several years before the group then reported on the use of cell-free DNA for chromosomal differences. Obviously, this technology has really exploded since the 1990s. This is a meta-analysis examining the accuracy of cell-free DNA screening or testing for a variety of indications, including Rh antigen. And this meta-analysis included over 10,000 tests for Rh antigen and reported very high sensitivity and specificity. And in fact, in this study, the test for Rh antigen outperformed screening for the common aneuploidies as well. More recent data shown here has shown even higher test performance characteristics for both Rh antigen and other antigens as well. So this was a study of more than 1,000 cases using next generation sequencing for NIPT, and they reported 100% sensitivity and specificity across the board. The authors concluded that not only is this, a highly accurate technology, but it also may help identify more pregnancies at risk than our current clinical practice for the reasons that we just discussed. So stay tuned because there's more to come on this at the end of today's talk. I'm just going to end with a few thoughts about NIPT for primary prevention. So the use of cell-free DNA to guide administration of RHIG is actually standard of care in an increasing number of European countries, though it is not yet recommended by ACOG. They did release a practice advisory in the spring of last year that stated that it is a reasonable consideration in the setting of RHIG shortages. And they acknowledged that this technology has very high sensitivity and specificity for the detection of Rh antigen. So I'm going to end here, and I'll share my email with everybody. We'll plan to have time at the end of the webinar for questions, and I'll hope that my colleagues will address anything that's left in terms of questions, and I'll hand it over now to Dr. Crispin. Thank you.
So I'm going to focus in the next couple of minutes about the diagnosis and treatment of fetal anemia. Nothing to disclose. Let's start with the clinical expression from the fetal side. From the maternal side, we usually don't see any clinical signs. From the fetal side, we see, we know that there's a hemolytic anemia that is going on, causing high cardiac output that could cause heart failure, and increased erythropoiesis that is causing the liver to be enlarged, and potentially hepatic damage and portal hypertension. So this is a classical picture of hydrops fetalis of a newborn that was born with significant anemia. And right above that, we can see the classical image of the sinusoidal pattern of the NST that we hope not to see anymore. The ultrasound images that help us do the diagnosis for hydrops demonstrating fluid in the fetal belly, or again on the bottom here, abnormal NST, fluid in the fetal chest, around the heart, or under the skin. All of these classical parameters of a hydrops. But again, this is a very extreme situation of an untreated fetal anemia. How do we do the diagnosis and try to prevent those cases? So many years ago, the way to do that was with draining some of the amniotic fluid and running it through an optic evaluation. And in a wavelength of delta OD of 450 nanometers, we could kind of evaluate the amount of bilirubin in the amniotic fluid, indicating the rate of hemolysis that is happening in the fetus. And this created the, sorry for that, oops, let me show it like that. This created, wait, am I not sharing right now? Let's see what happened here. Okay, this created a Lilly curve that came up with the numbers for this spectrophotometry, in which above a certain number we would expect the hemoglobin to be below 8, and this is how it was calculated back in the days. Now we move to less invasive options. And since the publication of this study in 2000 by Mary and colleagues, we now use ultrasound to diagnose fetal anemia. We know that by understanding the low blood viscosity and high blood flow speed, we can see a correlation between the peak systolic velocity in the middle cerebral artery, an artery that was chosen just because it's easy to get and reproducible. We get 100% sensitivity and very high specificity as well. Or in other words, from this original article, if we get an MOM of above 1.5 OM, we see that all the abnormal cases of moderate or severe anemia and high drops were above this line. We still have a few normals here, but that is a very low rate, allowing this very high sensitivity and specificity. What is the expected peak systolic velocity in each gestational age? And again, this is something that can be found in different tables and in different online calculators. But a rule of thumb that I often use is seeing a peak systolic velocity of twice as the gestational age correlates pretty nicely, at least up to 34 weeks, with 1.5 MOM. So even when you're still scanning and only seeing the peak systolic velocity, you can kind of estimate if you're going to be falling into the concerning range of above 1.5 MOM, indicating severe fetal anemia. And in this chart, we can see the way that we kind of classically manage those cases. And as some of those parts were already covered by Dr. Duffy, I'll run through them pretty fast. So when we know that the mom is positive, and this is just an example of an Rh positive, but could be, as we will discuss later on as well, different types of antibodies. We want to check the father's genotype if possible. If the father is homozygous, then we know that the fetus is going to be in a situation that might be concerning, and then we're moving forward with peak systolic velocity evaluation. If the father's genotype is negative, then we know that we do not need to be concerned, and we can stop the follow-up here. But if it is heterogeneous, then we can consider the free fetal DNA evaluation. We can also start with this point by directly evaluating free fetal DNA, if available, and then determining the fetus status and deciding if it's necessary to proceed with monitoring or not. Once we're at that point that we are concerned that the fetus would have an Rh different than the mother in this case, then we would proceed with peak systolic velocity MCA evaluation. But again, it could be a positive antigen that is different from Rh that will require this follow-up. And then we start monitoring, and if we see an increase in the MOM of above 1.4 and we're still in a lower gestational age before 35 weeks, we will proceed with chordocentesis in IUT. If we are above the 36 weeks, then we would probably consider delivery if this trend keeps increasing. And if the MOMs are below the 1.5, then we would just continue with sequential peak systolic MCA studies. About the MCA, we can talk for a long time about that, but in general, there are a few rule of thumbs that we need to follow when we're measuring it, so we can have a reproducible, accurate measurement. We want to not put a lot of pressure when we're scanning. We want to get an angle that is as close as possible to zero. We could allow a correction of up to 30 degrees, but the preference is to get it closer to zero. About the right or left MCA, we usually would choose just the one that has the best angulation and best picture. And with this number, we would go. Different groups might go with a mean or go with the worst, with the highest one. But I usually prefer just focusing on the one that is that looks best in terms of the image. And again, that we also need to see that it is reproducible, that it's not just one time that we got it abnormal, that it keeps repeating to seem abnormal in repeated evaluations. We have some limitations with peak systolic velocity in the MCA. We cannot really rely on that before 16 weeks. We used to have evaluations only after 18 weeks, but now we also have some nomograms going down to 16 weeks. The detection of moderate to severe anemia prior to 35 weeks is 87% in the setting of alloimmunization. So we know that it's not 100% still. We could get some false positives, especially if it's very late in the pregnancy. Another limitation that we have is after some transfusions, we can't rely on the peak systolic MCA anymore. And the one downside of not using the delta OD anymore is the fact that with the delta OD, we could, with the same test, also evaluate fetal lung maturity if we're considering delivery at some point. So not with this non-invasive procedure. The next step would be to consider an intrauterine transfusion. And for the intrauterine transfusion, there are also a few points that I want to mention. The access is naturally obtained under ultrasound guidance nowadays. We prefer to go into a venous access because the access to an artery can be associated with vasospasm, with bradycardia, and even can deteriorate and complicate with sudden death. In anterior placenta, those are usually the technically easier cases, which we can puncture the cord insertion side going through the placenta. With posterior placenta, that could be a little bit more challenging, and we might consider the intrahepatic portion of the umbilical vein if we cannot access the placental cord insertion. We prefer not to go into a free loop because when you start poking on a free loop, you might not get the access. And even if you get the access, once you start transfusing, you might lose the access. We start with a small blood sample and we proceed with IV paralytics in case this goes into the umbilical cord, just to make sure the fetus will not move, and with the movements, we will lose the access. And these are a few ultrasound images from cases that we've had. On the right side, you can see an access going through the placenta and anterior placenta right into the umbilical vein. On the right side, it was kind of a lateral placenta, so we were still able, on the left side, we were still able to get access into the placental cord insertion. But as I mentioned, sometimes you need to go into the hepatic portion of the umbilical vein, and this is an example of a case like that. You can see the streaming of flow once we get access into the umbilical vein. Another advantage with this case is that if you lose a little bit of the axis, or some of the bleeding that goes away is just goes into the peritoneum and being absorbed later on in the pregnancy. In terms of IUT, what else is important to remember? This is a procedure that was done many years ago, the same Lily that I described. The delta OD curvature started with transfusions. Naturally, back then, these were only intraperitoneal transfusions, as the ultrasound was not available and could not allow this axis that we have today, the preferable intravascular axis. The blood that we're transfusing, there are a few parameters that are important to remember. We want it to be Rh negative, CMV negative. We want it fresh so it will remain as long as possible in the fetus, with high hematocrit, so we will use as low volume as we can. We need it washed and irradiated. And you can see in this NST picture how different the NST can look before and after a transfusion. What is the volume that we're transfusing? We can use different tables that calculate the designated hematocrit according to the estimated fetal weight, and what is the volume that is required to add to get to that. But more practically is to use online calculators such as the one on perinatology.com, in which we can just put on all this information, the hematocrit of the blood that we're transfusing, what was the initial hematocrit. As I mentioned, we first tap and see what is the current hematocrit, what we want to get into, and I'll talk about that in a moment, and what is the estimated fetal weight, and you just get a volume. So what is the goal and what is the hematocrit that we want to get into? In general, we want to reach to 45% hematocrit, but we know that the end hematocrit that we're getting at the end of the procedure will not necessarily be the actual hematocrit, because fluid shifts from the extra to intravascular compartments, and we know that bleeding could still occur from the axis after we're done. Specifically with hydropic fetuses, or with those that have a very, very low hematocrit, we do not want to correct it all the way up, because they will not tolerate the volume overload, and we would usually consider repeating it after 48 hours. About intraperitoneal transfusions, these, as I mentioned, were the transfusions done a long time ago, but today we use it in situations of very early stages, and there is some data also showing an advantage of finishing the procedure, the intravascular procedure, with an additional boost of intraperitoneal transfusion that will maybe progress the interval, increase the interval between these scheduled transfusions. As for repeated transfusions, we don't want to get too much of a shift between the highest and the lowest hematocrit in those babies, and we want to maintain a hematocrit of above 25%, so we wouldn't wait too long between transfusions. We have a very rough estimation of hematocrit declining with 1% per day, and we usually recommend to repeat the intrauterine transfusion 14 days after. We remember that the peak systolic velocity could not be fully trusted after some transfusions. We usually do the last transfusion around 35 weeks and then plan for delivery 2 or 3 weeks after. As I mentioned, the peak systolic velocity could be different after we start transfusing with adult red blood cells. But overall, the combination of the trend of the peak systolic velocity and mainly the timing from the last transfusion would determine the next transfusion. All right, thanks so much. And I would finish with that and leave time for questions at the end. So now to Dr. Davenport.
Great. All right. Thanks so much. My name is Patricia Davenport, and I'm a neonatologist here at Boston Children's. And I'm going to talk about neonatal care and management. So I think most people here are probably on the prenatal side more than the neonatal side. So hopefully I have some just really pretty pictures for you if that is the case. But really important in these cases is preparing for delivery. And it really depends on the severity of the fetal course, what sorts of preparation need to be made for the delivery room. And also, I think also on what the antigen is. Obviously, RH versus KEL can have different implications for the severity of anemia. And so really focusing on cases with severe anemia, plus or minus high drops, delivery at a level 3 or 4 NICU is incredibly important, where there's a 24-hour neonatal presence for delivery. Of course, consideration of glucocorticoids to accelerate lung maturity when appropriate if the delivery is expected to be premature. And just thinking about the tolerance of delivery, mild and moderately anemic infants usually will tolerate labor, but severely anemic infants may not. And so really just preparing for resuscitation after delivery. And this part I'll emphasize a few times throughout it, but the NICU really needs to have early and close communication with the blood bank to prepare the correct blood, either ABO matched or O negative blood. That, of course, is negative for the antigen. So briefly, just talking about the delivery room care for these babies, really initially it's routine resuscitation, it's NRP, and it's really focusing on getting an airway and supporting the baby's respiratory and hemodynamic status, and quickly obtaining vascular access. This definitely can be a low-lying UVC in the delivery room. Some centers might choose to have a PIV placed first, depending on how skilled the nursing delivery room staff is on obtaining that. But that really should be the next point. It can happen simultaneously sometimes. Sometimes it'll happen after the initial respiratory support. And this is just an important point that if bradycardia in the delivery room is unresponsive to ventilation optimization and really the poor clinical status of the neonate is likely due to the severe anemia, it's just really important that the team still initiates chest compressions and code meds and does normal NRP while preparing for transfusion. Even if the team knows transfusion is the thing that is going to help this baby, it's just so always crucial to make sure we're following the algorithm and supporting this baby while we get everything prepared to administer the red blood cells. So there's some really important transfusion considerations that kind of span from the fetal time to the postnatal time. And again, just really talking about close communication with the blood bank is just so crucial. It takes them a little bit of time to make sure they can get the right blood for these babies. And so just early and ongoing communication is important. And really the thing to think about the most is rate of transfusion. So in the delivery room, of course, blood may need to be rapidly administered, especially if this baby is having a code situation. But really the ideal situation for these babies, especially ones with severe prolonged anemia, is to stabilize the baby in the delivery room and maybe initiate a transfusion, but really transfer them to the NICU where there can be a much more controlled management of their anemia. And infants who do have severe prolonged anemia, again, plus or minus high drops, really might need an exchange transfusion rather than a regular blood transfusion, again, to minimize the circulatory overload, knowing that they likely have some depression of their cardiac function and really trying to prevent the progression into fulminant heart failure. There's a little detail here. Most centers have their own protocols for how they like to do their exchange transfusion, but really, even if you wanted to start it in the delivery room, you can start by just removing 5 mLs per kilo of an infant's blood and replacing it with the same volume of whole blood over several minutes. And you're going to repeat this over and over again. And the average volume is about 80 mLs per kilo. So if you divide that by 5, this is about 16 cycles needed to replace the infant's entire blood volume. And obviously during this, there are protocols for the close monitoring of hemodynamics, electrolytes, temperatures, glucoses. There's a lot of continuous monitoring that needs to be done during an exchange transfusion. And if a baby is moderately anemic, they still need consideration of the rate of transfusion. It should be a slow transfusion of 10 mLs per kilo and over a 2 to 3 hour period. Once the blood is released from the blood bank, it actually usually has about 4 hours between the time it's released and the time that the transfusion needs to end. And so you could even run it slower as long as you're staying within the parameters that the blood bank gives you. All right, and so thinking about further management in the NICU, really most infants with fetal anemia should come to the NICU for hospitalization after the delivery room, even if they seem to be doing well. There's a lot of other considerations that need to be monitored. Primarily, of course, their anemia. They need very close monitoring during red blood cell transfusions that really could not be administered on a pediatric floor or lower level of care. And they need close monitoring of their respiratory status and their hemodynamics during transfusions because they really can develop respiratory distress or progression of their heart failure that needs support. And early monitoring and aggressive treatment of their hyperbilirubinemia is incredibly important. Obviously, with different antigens, the severity of hyperbilirubinemia and also of anemia will vary. So it is really important for the neonatologist to know what antigen is present. For example, ABO incompatibility, which has minimal consequence in terms of anemia, has very high risk of hyperbilirubinemia. And anti-kel, because it actually affects both hemolysis and erythropoiesis, has much more severe anemia than RH. And so these are all things just to think about as we, try to predict what the infant's course will be and how much treatment and monitoring they need. And obviously treatment of hyperbilirubinemia is phototherapy, lights and blankets, adequate hydration, and consideration of IVIG therapy. And finally, thinking about discharge, the timing of discharge for these infants, of course, depends on having a stable anemia and no longer requiring transfusion to maintain a stable hemoglobin or hematocrit, resolution of their hyperbilirubinemia, and of course, achievement of our normal NICU metrics. So whether they're preterm or term, if they needed respiratory support, they have to be successfully feeding. There's a whole host of things that we look at for every baby before they're discharged from the NICU. And one important thing that I think sometimes is overlooked is really the importance of follow-up for these babies after discharge. Of course, they're going to be followed by their normal pediatrician, and sometimes also pediatric hematology. It's never wrong to consult them during the NICU course and see if they'd like to follow the baby postnatal or after discharge. And many of them do actually follow at least once with a pediatric hematologist. And a lot of this is really just because these infants are going to need earlier monitoring of their hemoglobin and hematocrit than routine pediatric care. So if anyone has children or is a pediatrician themselves, they know it's actually not usually tested in the clinic until 9 to 12 months. And these babies may have a more severe physiologic nadir. And so it actually sometimes can even require repeat transfusion as an outpatient. And so these are important things to make sure are signed out to the pediatrician during the NICU handoff. And then finally, of course, important things to think about for families and babies are long-term outcomes. And I'm just going to briefly review a lot of studies in a few sentences, but a lot of studies that have been done on this focus on infants who were treated with intrauterine transfusion. And the majority of these show that despite severity of disease, developmental outcomes for children who are treated with intrauterine transfusion is really normal. And these studies followed babies to 2 years, 5 years, 6 years. So really, there's been some really nice longitudinal studies looking at these outcomes. And then there's a host of studies that also just look specifically at fetuses that do end up developing hydrops. One study looked at 18 fetuses that had hydrops and were treated with IUT, and they found that there was, as expected, a higher percentage who died or had major neurologic morbidity, and out of survivors, 12% also had major neurological sequelae. And I think this goes in hand with the severity of critical illness also in these babies. And then one slide just on the LOTUS study, which I'm sure people on this call are even more familiar with than I am, but this was looking at the follow-up after intrauterine transfusions. It had a large number of babies, 291, and they looked at long-term outcomes. So you can see the age at follow-up was 8.2 with a range from 2 to 17 years. And as you can see here, these are percentages in the brackets. Really, the percentage that developed severe disabilities, cerebral palsy, bilateral deafness is all very small. About 5% had neurodevelopmental impairment. And when they looked at babies with severe hydrops, that was associated independently with neurodevelopmental impairment with an odds ratio of 11.2. And this was just a nice graph, I thought, from the study that showed hydrops in red, no hydrops in blue, and on the left here is the IQ, and on the bottom is your hemoglobin level. So really just showing infants that are hydropic have, I think, as everyone would expect, lower hemoglobin levels at the time of IUT, but also an associated drop in their IQ. And again, I think this is probably anemia, hydrops, and then the critical illness afterwards in intensive care required in the NICU. So just a brief summary. Hopefully I didn't make you yawn or bore you too much. But infants and pregnancies complicated by fetal anemia really require a well-prepared delivery room team, close postnatal monitoring in the NICU, thoughtful transfusion practices, a really great involvement with the blood bank, and close follow-up by their pediatrician. And I think reassuringly long-term outcomes for these babies that are treated appropriately are very favorable. And I think it's important to know that these infants who do develop high drops do have a higher risk of neurodevelopmental impairment and probably require closer monitoring after discharge, meaning like, referrals to early intervention and just kind of the routine screening that's done for children, but maybe a little closer eye on these babies. And these are my references, and with that, I'll pass it over.
Thank you very much, Patricia, for a great talk. Now it's my turn, and I just get into the very concrete of the current research that we perform, some of the concerns that we have, and some of the practical standpoint of treatment. Okay, let's start it. I mean, it's coming here as fetal anemia. When we do have how we would want to diagnose a fetal anemia, I think there was a discussion in the past that I don't need to go through it, but now we're coming down to the to see and coming to look at is what is the accuracy of cell-free fetal DNA in this era, and this is a recent publication that we have is we just had a publication that is in press in an American Journal of Obstetrics and Gynecology, AJOG, which we did look at the diagnosis accuracy of cell-free DNA, and as you can see it here, the sensitivity and specificity of the test is incredibly high. Specifically, we have more data for RH isoimmunization. Therefore, again, the test is excellent, and both the sensitivity and specificity is very good. And even you do use a different techniques, you still stay with a 99 to the 100% of sensitivity and specificity for diagnosis of the cell-free DNA. With that said, again, in the conclusion of the paper, which will come up very soon, the cell-free DNA is a highly accurate and reliable tool for detecting a fetal red blood cell genotypes. And the advantage is cell-free DNA to the amniocentesis is a non-invasive test. And at this point, we strongly believe that the first line should be the send for cell-free DNA. The best time for sending it is 10 or after 10 weeks. And this will be the first line. With that said, again, the importance is if you do send for a cell-free DNA and your antigen is negative, there is no need for further evaluation. That means the patient do not need MCA Dopplers or anything else. You go to the routine care. And I think that's also coming down to the expert opinion that we recently published in AJOG. And therefore, I think that's the step forward that, please send the cell-free DNA. You can send it at 10 weeks. And if it's negative, just do the routine care. And there's no other follow-up needed. The other thing that recently we work is in a subset group of the patient that we had a severe or early isoimmunization, or the baby that we had prior stillborn or any of those that fall in a severe category. we can start, and it's better to do IVIG started from 10 to 14 weeks. Even you can start IVIG before you know the antigen status. And if you get the antigen status and still confirm that is an antigen negative, then still you can continue with the IVIG. The way that we do the IVIG is usually we started at 10 to 14 weeks. That means early in a pregnancy is better to start at less than 13 weeks. Mostly we do it at 1 gram per kilo, and we do not need to do any loading dose. And for IVIG, it's better to start it in a clinical setting because a small proportion of the people can have allergy to the medication. And also, if you do use it for blood type of A, B, AB, definitely you need to look at the pregnant person, make sure the pregnant person will not creating any kind of the hemolysis. Therefore, I do believe if you want to do the IVIG, it's better to send this patient to the fetal centers. Definitely the IVIG show information that it will be delayed the gestational age at first IUT on that pregnancy. And also the data shows that the gestational age at first IUT was later in a group that start IVIG. Therefore, that's a huge benefit for starting early IVIG in that high-risk group. And also shows that the fetal hydrops will be significantly less, and the improving of the prenatal outcome, which will be the fetal demise, live birth, more than 28 weeks and 32 weeks, and a higher surviving rate in this group of the patient. Therefore, as a general, it's better to, on a very high risk, early Alloimmunization, start IVIG because you do have a lot of good benefit. Even before the IVIG on that group, there's a small group of the patient can benefit from plasmapheresis. The other thing is about the titer. That means, when you have a patient, what is a critical titer? If it's a non-kill antibodies is equal or more than a 16, but if you do have a kill, is equal or more than a 4. And then that's also coming down to our consensus, which we did publish a couple months ago. And then the algorithm is also important. If you do have a high titer, then you initiate it with the MCA Dopplers. If it's less than a 1.5 MOM, then the delivery time will be between 37 and 38 and 6. But again, if you do have a 1.5, then, as Dr. Crispin mentioned about, we go through that kind of the pathway of transfusion. We did move the MCA Doppler ultrasound screening to the 15 weeks. That means in a previous discussion was almost 16, but now we're moving down to the 15 because a small group of the patient can be diagnosed at 15 and can be treated at 15 weeks. And then it will be doing weekly, and it will continue until the delivery. The other caveat is we also reached the consensus that if you diagnose a baby with a high MCA peak systolic velocity, more than a 1.5 MOM, it's better to send it to the referring center without giving the steroid, because we figure out sometimes with getting the steroid, it will shows and will bring the MCA peak systolic velocity lower. Therefore, it's better to send them to the fetal centers or your referring center, because they can evaluate, and if they confirm that is a high, then they can get a steroid, and then they can prepare the patient for POPs and then possible intrauterine transfusion. The other caveat is when you do the IUT, when you will stop it. The stop end will be until the end of the 35 weeks. That means we can go up and transfuse these patients, and this is coming from expert, Delphi study that we just published. We can do it up to the 35 and 6, and we can transfuse these patients. When we finish with the transfusion, mostly we require for delivery 2 to 3 weeks after the last IUT, which, if you finish it at 35 weeks, usually we propose to deliver those babies around 38 weeks. But if you do have a severe anemia and high drops, then that will be different, and then the delivery will be adjusted to the individual patient. Mode of the delivery, it can be a vaginal delivery. There's no need for doing the C-section, and also we recommended that antenatal testing started at 32 weeks. And then delay cord clamp is recommended in non-hydroptic IUT pregnancy to allow for placenta transfusion. The other thing is, fetus with the antigen status, if it's again negative, as mentioned, routine OB care. If it's unknown, then usually we recommend to deliver at 37 to the 38 and 6, even the MCA is normal. We also, recently performed a meta-analysis, and through a meta-analysis, we figure out that it's still in a good era of IUT, which we are doing it for decades. Still, 1 out of the 5 of the cases can end up with a fetal or neonatal death. Therefore, at this point, there is a medication called Peculoma, which is a medication that will be block the receptor of the IgG, and it will prevent of the transferring of the maternal IgG to the fetus, which will be stop the process of isoimmunization to getting those antibody and then causing the fetal anemia. The first phase 2 publication that recently published in New England Journal was very reassuring and show tons of the benefit for a very high-risk group in a way of now the Johnson & Johnson went to the phase 3 of the study, which is called as the Azalea study, and the Boston Children's is a part of it, and hopefully in the next months we can start recruiting in a way of, we do believe that probably that medication will help, and you need to go to the again, randomized clinical trial for sure of the proven of the effect of the medication. But with that said, this is a new type of the research, and hopefully if the medication on the phase 3 is coming down with a positive result, we can prevent of many of these intrauterine transfusion, which is still, we believe, will have a tons of complication. With that said, again, I need to thank my all research fellow through my career, and I couldn't do this without their help. Thank you very much.
Great, thanks, Shami. I looked at the questions we got, and I think you perfectly answered both of them in your presentation. And we're at time, so if there aren't any additional questions, I think we can wrap up.
There is one question in the chat as opposed to the Q&A that asks, when we think cell-free DNA screening will be endorsed by ACOG and SMFM.
No, that's excellent. That's why we did that meta-analysis, and it will publish in the AJOG. We're in a close communication with them, and hopefully they will endorse it soon, because the pile of the evidence that we have in the literature at this point are very reassuring.
I think we can conclude here. Thank you, everyone.
Thank you very much.
Thank you.
Thanks.